Morning, everybody. Morning, and welcome to the AICC conference. I'm delighted to see everybody here. I feel it's just amazing, isn't it, that we've got through the last 2 years and we've all made it. And brilliant to see people in person. And welcome very much to all of you online, anyone who couldn't make it here today. So we have a very tight agenda. We have some fantastic speakers, and we look forward to hearing them. I was just talking to Nigel Wheeldon, who is sat here in the audience, who was really very much, I guess, the founder of this association. And I think between us, we've kind of realized this might be the 10th anniversary meeting. Not quite sure, but it's been fantastic. I hope today's program matches up to your expectations. I'm sure it will. And so with that, I'm going to hand over to my co-chairs here. And that's Catherine Mercer, Secretary of the Association, and Eleanor Wicks, who has been helping us organize today's event. So Eleanor and Catherine, over to you. Oh, I do need to say there will be a fire alarm check between 10:30 and 11:30. We don't need to do anything. We can stay still.
Fantastic. Thank you very much, Jan. So just really for the benefit of the virtual attendees, just a little bit of housekeeping in general is you are able to raise your hand. You can come up live onto the screen should you wish when we do the Q&A towards the end. And there are a few emojis if you're up for it. Please do tweet. As you can see, our hashtag is hashtag AICC 2021. So please tweet widely and feel free to take as many photos of the speakers as you wish. Sorry, speakers. So without further ado, I'm going to hand over to Catherine so that we can introduce the first session.
So the first session is updates in inherited cardiac conditions. I'm delighted to see you're a minute or two early because we've got so much to fit in. I'd like to invite our first speaker to the stage, who's Professor Elliott, who's known to many of you, consultant cardiologist at Barts, and also very high profile in the cardiomyopathy world.
Sorry, we've got the wrong slides up there. If you can change it, Professor Elliott, please. Thank you.
I can be Pier Lambiase if you want me to. Okay, so thank you very much. Great to be here. As you say, let's get rid of this damn thing for a moment, shall we? So as always, L sets impossible targets. Yep, to cardiomyopathies in 15 minutes. So let's give it a go. The term cardiomyopathy, first used in 1957. I don't know if any of you have heard of this guy, Wallace Brigden. I advise you to go and read this paper because he set out a series of questions and observations at that time, which we've only just started to answer. His definition was very similar to our current definition of cardiomyopathy. Basically, it's very simple. It's a bad heart muscle. So it's a bad heart muscle which isn't explained by abnormal loading conditions or coronary disease. And he said then in 1957 that the true incidence of cardiomyopathies is unknown, but probably much more common than is generally recognized. And I think that's still the case. It's very difficult to get estimates. Many others have been peddling numbers like 1 in 500 for hypertrophic cardiomyopathy. That's not right. Okay, if you look at people within the system, it's less than that. This is a best guess based on ICD-10 codes, and it's about 4 in 10,000, something like that. But this figure shows some other very important things, which I think shatter some of the misconceptions about cardiomyopathy. The first is that DCM is far more common than HCM. We know that because we see DCM every day in our practice. And the other thing is that the peak prevalence is not in your 20s or 30s, it's in your 50s or 60s. So these are not diseases just of the young. The other thing that's happened is if you look at the reporting, because I don't think this is an actual increase in the prevalence of these diseases, it's increased by 60% in less than 10 years. So there's the reluctance to use these diagnostic labels has clearly changed as a consequence of education and awareness. In terms of etiology, Wallace said, cardiomyopathies, like any organ in the body, can be affected by all the processes, the diseases that affect any organ in the body. And therefore, we should strenuously try to avoid the term idiopathic. And I think now we're in an era in cardiomyopathies where actually we can do that. If you say idiopathic, it's usually because you haven't looked hard enough. And that was the sort of gestalt behind the so-called classification of cardiomyopathies, which was everything in the top line there is not a diagnosis. HCM, ARVC, DCM, these are descriptors, which are explained by a whole family of genetic and non-genetic diseases. With regard to the genetics, the first one out of the trap was hypertrophic cardiomyopathy, with a description of a mutation in the gene encoding beta-myosin heavy chain back in the late 1990s. The Seidmans, Bill McKenna, and many others studying enormous families, which are a godsend to genetic researchers. And of course, we soon realized actually the genetic architecture was much more complex than a single gene, but most of it seemed to affect genes that encode other protein components of the cardiac sarcomere. And the story has sort of grumbled on. We now have this tale of sort of rarer phenocopies and genocopies, some genetic, some rare, actually about 1% recessive forms. And also the recognition that within our clinics, those people that we've been labeling as hypertrophic cardiomyopathy may have other disorders such as Fabry disease, and now increasingly a focus on amyloidosis. So this story, of the hypertrophic cardiomyopathy is an umbrella term, if you like, encompassing a range of diseases you can apply to each of the phenotypes. So in dilated cardiomyopathy, big baggy ventricle that doesn't contract well, which isn't explained by hypertension or coronary disease. And the way in which we organize textbooks, review articles, is usually to produce lists like this, which are utterly useless because they imply an equivalence in these different causes. Not knowingly at least, I don't have many people in my clinic with arsenic poisoning. Genetics. For 20 years or more, if you look at families, then it's about 1 in 4 individuals will have evidence for a genetic predisposition. The genetic architecture is more complex than hypertrophic cardiomyopathy. It involves genes encoding proteins all the way from the cell membrane through the sarcomere, the nuclear envelope. So 80 genes, I don't know how many genes it is now. And if you do genetic testing in people with dilated cardiomyopathy, if you have apparently sporadic disease, you've got a 1 in 4 chance of finding a pathogenic variant. If you've got a family history, you're up to 1 in 2. So genetics are a significant part of so-called idiopathic dilated cardiomyopathy. ARVC, same story. So classical ARVC defined by fibrofatty replacement of the right ventricle, also in the left ventricle. The disease is, the paradigm for this is this disease of the intercalated disc. So the genes that encode proteins, desmoplakin, desmoglin, plakophilin 2. But just as in DCM, just as in hypertrophic cardiomyopathy, there's then a tail of rarer causes. But in ARVC, if you look hard enough, you'll find a likely pathogenic or pathogenic variant in maybe 60% of cases. For classical ARVC, it may be as high as 70 to 80%. So that's all very well, but what has been the impact of a genetic diagnosis on cardiology practice? Well, we have to face the fact that as cardiologists, it's not like oncology. Oncology is about a tissue diagnosis. In cardiology, we depend almost entirely on surrogates for disease processes within the heart, with a heavy emphasis on imaging. And the imaging has evolved with the technologies available to us. In recent years, we've been getting a little bit closer to non-invasive interrogation of the underlying substrate. So looking at fat content in Fabry disease, particular patterns of scarring which associate with particular diseases. We've started to see, I think, some convergence now between a genetic diagnosis and the images that we see in clinical practice. when I want to pick a fight with my MRI colleagues, I'd say to them, you don't understand the power of your technique. Of course we do. We measure T1, T2, da, da, da. No. The power is pattern recognition. Because if you've got someone who's got unexplained left ventricular dysfunction, and you start seeing mid-wall scar in the septum, ring patterns like this, immediately your differential diagnosis should narrow down to a small number of genes. This is genetic disease, even if it's a subepicardial pattern. And then we've got some old tests which give us a tissue diagnosis non-invasively. Bone scans, bone scintigraphy. So you've got someone, you've got an 80-year-old or a 75-year-old male with unexplained left ventricular hypertrophy, and you do a bone scan and the heart lights up. And in the absence of a plasma cell dyscrasia, that is TTR amyloidosis. And this is the technique which is showing us that maybe 10% of HFpEF is amyloidosis. Yeah. So you can, we can really riff on this in the clinic. Look what I found. But what difference does that make to management? And so the slide, I've been using for years is, well, if you make a genetic diagnosis, it's very helpful to confirm diagnosis, family screening, perhaps to prognosticate. And I would like to think it helps prevent disease-related complications. What is the evidence for that? Well, in terms of diagnosis, that's increasingly true. You shouldn't, though, be thinking of this. I've got someone who's got a bit of LVH. Let's do a gene test to decide whether it's hypertrophic cardiomyopathy or not. That's not how you use genetic testing, because a negative test doesn't necessarily mean that it's not a genetic disease. But if you've got a phenotype which fits, then in hypertrophic cardiomyopathy, genetic testing can be extremely helpful, defining this range of very different diseases with very different natural histories, and in some cases, very specific therapies. In terms of prognosis, this classic study by Hugh Watkins, going in 1990s now, these survival curves for families with different mutations in troponin T or beta-myosin heavy chain, showing this differential outcome. I think where we are in hypertrophic cardiomyopathy is still essentially that if you've got a mutation, you tend to do less well than if you don't have a mutation. But the future, which is almost there, is that we're not really interested in one gene versus another. If you think that through, that's a pretty naive approach to using genetic information for prognostication. What we're really interested in is the effect of individual mutations. And we're starting to see data now which separate out survival according to specific mutations. Where the money is, though, at the moment, is in dilated cardiomyopathy. It's the stuff that's hidden within the noise. So if you look at DCM, this is from a series in Denver, in the US. So once again, it's probably a slightly enriched cohort, but a third or more of patients with dilated cardiomyopathy have an identifiable mutation. And if you compare those with and without in terms of their risk of ventricular arrhythmia, then those with the mutation have got a higher risk. But that risk is conveyed by very particular mutations to specific genes. In this case, desmoplakin and lamin. These phenotypes hiding within heart failure have a very different natural history, and in terms of ventricular arrhythmia, potentially preventable sudden cardiac death. And certainly in our own practice, this is where I think genetics has had the greatest impact so far, is in the stratification of dilated cardiomyopathy. And I say not all DCM is the same. Some of it is mostly about heart failure. So mutations in BAG3. BAG3 is a target that you hit all the time, which is interesting for other reasons. But this is mostly a heart failure gene, rather than a sudden death gene. In terms of family screening, it allows you to screen individuals. If you identify the mutation in the proband, you can then identify those who require screening. But if you've got a relative who carries a variant, what is going to happen to that individual? And it's only relatively recently we've started to get data that show us that. And this is in hypertrophic cardiomyopathy, where if you look at mutation carriers identified as part of family screening who don't have evidence for disease at baseline, within a 15-year window, particularly the men, more than 50% will have developed disease. And it's only when you develop disease that you become prone to disease-related complications. And it's these kind of data which I think allow us to maybe rationalize a little bit the way in which we follow patients. If you're male, you've got an abnormal ECG at baseline, of course, your chance of developing a complete phenotype is much higher. Okay, yeah. But, cardiology is about doing stuff. So in the heart failure world, big trials. This is looking at sudden death rates in some of the pivotal trials, showing this gradual reduction in sudden death just by giving beta blockers, ACE inhibitors, spironolactone, Entresto, DAPA, all the rest of it. And even in cardiomyopathy land, you can show that the impact of good evidence-based therapies is pretty impressive. So this is from a large DCM series from northern Italy. And here you see the 70s, 80s, 90s, 2000, with this reduction in mortality from heart failure, sudden death. And this is nothing to do with defibs. This is about beta blockers, spironolactone, ACE inhibitors. So, does the genetic diagnosis matter there? In hypertrophic cardiomyopathy, well, we haven't got anything. If you look at this, HOCM is heart failure. If you have disease for long enough, you get heart failure. And we have nothing that we use knowingly that prevents that from happening at the moment. So this, I think, is the final frontier in cardiomyopathies, showing that making a diagnosis has impact, and impact is necessarily therapy. And this is where there is now an enormous amount of activity and interest in cardiomyopathy land. The notion of genetic therapies is already with us. Familial hypercholesterolemia, you make a genetic diagnosis that already influences how you manage your patient. In cardiomyopathy, our case has relied on rare diseases like Fabry's disease. Well, if you make that diagnosis of Fabry's disease, you can give them enzyme replacement therapy. But I think the paradigm shifter has been amyloidosis. Because at long last, as cardiomyopathy doctors, we can say, look, you see, we told you it was there, and it makes a difference. Amyloidosis, different types, AL amyloidosis, which is not common, TTR amyloidosis, which is actually really quite common. And it's important now because, with the exception of the United Kingdom, there is now a therapy which reduces mortality by 30% and prevents or slows disease progression. And that's a drug called tafamidis, which stabilizes the dissociated protein, TTR, what we used to call prealbumin. 30% reduction in a population with a median age of 75. The exciting thing here, though, is that tafamidis is probably a relatively weak drug in this context. And we've got other ways of reducing TTR production by using gene therapy, so antisense oligonucleotides or silencing RNAs to knock down production of TTR within the liver. And trials are now underway using these technologies in cardiomyopathy specifically, but we already have some signals suggesting these drugs are effective, not only in stabilizing disease, but maybe, this is BNP levels in the Apollo trial, starting to come down. So maybe there's a reversible element to amyloidosis. But it's not just about amyloidosis, it's about structural genes too. So laminopathy, about 5%, maybe 8% of dilated cardiomyopathy. Lamin, an important part of the nuclear envelope, part of this family of proteins, very important in control of gene transcription. It's a phenotype which pretty much does what it says on the tin. So you start to get atrial arrhythmias when you're young, you then get conduction disease, you then get ventricular arrhythmia and die suddenly, and then you get heart failure. We already factor it into what we do in terms of preventing, in terms of management, so lower threshold for considering defibrillators. But now, sorry, horrible slide, but based on our understanding of the downstream pathways that cause disease in laminopathy, identifying therapeutic targets, and now doing randomized trials. And the result from this, what was called the ARRAY trial, the preliminary cut will be available by Christmas, as I understand it. We'll see. And then finally, even my old friend, hypertrophic cardiomyopathy. there's even progress here. Going back to what we understand about the basic pathophysiology of this disease and understanding what it is that mutations do to this interaction of the filaments within the sarcomere, heavy chain, light chain. And we're now, thin filament. What we now realize is that some mutations cause, if you like, a hypercontractile phenotype at a cellular level, which we can now inhibit with specific molecules. And the drug is called mavacamten. And horror of horrors, a randomized clinical controlled trial in hypertrophic cardiomyopathy, which shows in patients with outflow tract obstruction, you can reduce the gradient, improve exercise tolerance, dramatically reduce the BNP and troponin. And the ball is now rolling downhill. So we're now getting other genes, other compounds which do the same thing in a slightly different way. We've got those which are now targeting the sarcomere to increase that interaction between the heavy, so the thick and the thin filaments in patients with dilated cardiomyopathy. And of course, we're now starting to think about gene therapy. So correcting the underlying genetic abnormality. Now, this is not easy. There's all sorts of barriers that we have to get over in gene therapy, but it's being thought about and going through phase 1 studies now. And of course, you've got the science fiction of being able to chop out the bad gene and put in the new one using CRISPR-Cas technologies. CRISPR-Cas, if you like, the equivalent to the immune system within a bacterium. Sort of a memory of previous exposure to viruses in the form here of these guide RNAs, which bind to this protein Cas9, which can, in bacteria, recognize foreign DNA, bind to it, and cause breaks in that DNA or RNA, and through the usual processes of clearing out bad DNA in the cell, get rid of viruses. Well, we're now using that technology to not just simply make cuts in DNA, but to turn genes on, turn genes off, maybe put new genes in. And this has now been done in amyloidosis. Is it possible in the heart? We'll see. But at least we can imagine. So big bucks. And so my hope, my belief actually almost now, is maybe 5 years, it may be 10 years, but we're going to be moving from this, which is what we have now, to something much more like this. A range of therapies, a thought process analogous to that that's now commonplace in oncology, where we say, not is the heart thick, not is the heart dilated, but what is the underlying basis of this disease? And do we have a specific therapy for that? Thank you very much.
Thank you so much, Professor Elliott, for that fantastic start to our conference. It just underlies what an exciting field we're all in. And I think if Wallace Brigden could have seen your talk today, he'd have believed we were already in the realms of science fiction. It's really exciting where we're going. We're saving questions till the end of the session. So I'd like to invite Professor Pier Lambiase to speak the next talk. We're going from heart muscle to electrophysiology. Do fire away, Pierre.
Thank you very much. Thanks to the organisers and especially Els, who sent me a text at 3 o'clock this morning to remind me where the meeting was. Since I've only been giving lectures from maybe a lounge or a cupboard at the back of the cath lab, it's quite nice to actually give a face-to-face lecture. So in 15 minutes, I'm going to give you a tour of updates in channelopathies. Just to give you the background, so I'll start with Brugada syndrome, because there have been a few developments in risk stratification this year. Brugada syndrome, most of you are aware, COVID elevation inducing VF in the proportion of patients, and there's a range of patients at risk with up to 5% per annum risk in those who've had a prior cardiac arrest and a type 1 ECG, down to those where we administer adrenaline and demonstrated Brugada pattern ECG with a 0.3 risk percent per year risk. So overall, we've got this huge range of risk, and we're very good at spotting these and putting in ICDs, and we're very good at telling these patients to avoid drugs that are proarrhythmic. But we're stuck with this intermediate risk population. And people have tried to use VT stimulation studies to predict risk, but that's very much by the by and not really routinely used. So we need other strategies. And of course, we want to start with simple approaches, for example, using the surface ECG, and that's starting to emerge now to look at ECG risk markers. This is a paper published a couple of years ago from a French group. They looked at patients who'd had a prior cardiac arrest, as well as patients who were asymptomatic with Brugada, and identified a number of markers such as early repolarization, short T peak to T end interval on the T wave, and of course the resting type 1 pattern. And they combine these into different levels of risk. And the principle here is using these ECG markers to enable you to risk stratify more precisely. This was a secondary prevention population, so in a significant proportion, so not really that helpful, but the concept is there. We looked at a population of 1,000 patients across Europe and also including Brazil who were asymptomatic, because we wanted to home in on a population of asymptomatic Brugada patients. And we went through 16 different ECG markers that have been proposed to be at risk. And the most important markers we found were early repolarization in the inferolateral leads, and also in a small proportion, patients who had a Brugada pattern in their peripheral leads, as well as in their standard chest leads from V1 to V3. The other risk marker was prior syncope or arresting type 1 pattern. And what we did here is that we followed the Elliott principle of trying to take these risk markers when you're sitting in a clinic so you can communicate a level of risk to a patient around which you can then have a discussion about management. And so we came up with this very simple risk score where we can, due to the hazard ratios, we can ascribe points to particular markers. So for example, if you have a type 1 resting ECG and also early repolarization, that gives you 21 points if you combine it together, which gives you over 10% risk at 5 years to have a significant ventricular arrhythmia causing syncope or a cardiac arrest, or an appropriate ICD shock for fast ventricular tachycardia of more than 200 beats per minute. And then one would strongly consider an ICD for such a patient. We also stratified the levels of risk at which you would intervene with an ICD with, for example, patients with less than a 3% risk, you would implant more a lot of ICDs that may, more than 3% risk, you would implant a lot of ICDs and not miss anybody with not having an ICD and then dying of a cardiac arrest. But of course, as the threshold of risk rises, you may start missing more and more patients without an ICD. But interestingly, at a 3% threshold, you need to implant 9 ICDs to save 1 life, and at 5%, you need to implant 8. So essentially, with this level of risk, you can then calculate on a cost-efficacy basis how many ICDs you would need to implant to be effective. So this has moved on a little bit more in terms of Vincent Probst took a population of Brugada patients who'd either had a cardiac arrest or who were asymptomatic, and he used the Shanghai score, which is a diagnostic score using a combination of ECG markers, family history, and genetic testing. And of course, a bit like the Schwartz score for long QT syndrome, the higher your Shanghai score is, the more likely you are to have Brugada syndrome. And he was able to then break these patients down. So if you had a score of, say, 2 or 3, which basically means if you had, for example, a drug-induced adrenaline positive ECG and a mutation that may be pathogenic, your risk is relatively low. But as you go through with syncope or family history of sudden death, then the points accumulate and your risk of a significant ventricular arrhythmic event or sudden death also increases. And he compared this to a simpler score, which was Sierra, where he took spontaneous type 1 ECG, family history of sudden death, inducible VT EP study, because he's from the Brugada group, and this is the only group that uses VT stim clinically routinely, syncope, sinus node disease, and prior cardiac arrest. And you'll see here, if you have a Brugada ECG alone with a type 1 pattern, your risk is relatively low over 10 years. It's about 3 to 5%. And that's similar to the level we found at 10 years in our population of 1,000 patients. But he compared the area under the curve for the Sierra score and the Shanghai score and found they're essentially the same. What's interesting in this is that in this whole population that were being managed as we would routinely in clinic, according to all the different foibles of clinicians in the Brugada clinic, as it were, 16.5% of ICD patients had events, so those that got implanted with the device had events, versus 1% of patients who didn't have an ICD. So despite us really trying to push the envelope to optimize risk stratification, sudden death occurred in 1% of patients without an ICD, which is 0.15% per year, which is actually equivalent to the sudden death in the general population. So we're actually doing quite well at identifying high-risk patients, but obviously we want to miss as few as possible, but minimize morbidity of the device as we implant. So moving on to the genetics, well, we know very well 25 to 30% of patients have these sodium channel SCN5A mutations, but this is a huge gene, and there are a lot of linker regions of the gene which are not pathogenic. And this is a study that's published this year in European Heart Journal, where they looked at the function of the sodium channel mutation on the sodium channel current, identifying loss of function mutations. And they found that overall lethal arrhythmic events occurred in this group of patients from Japan in 2.5% of all Brugada patients, with the highest incidence occurring in these loss of function sodium channel mutation carriers. And you can see here, it's quite a busy slide, but essentially they look at arrhythmic events. They also looked at ICD shocks and syncope, and it's the loss of function mutation in patients that had the highest burden of these events, as opposed to the non-loss of function mutations. So this is important because this is, again, alluding to what you've heard on the cardiomyopathy talk, actually now understanding the functional importance of a gene mutation implicating prognosis and management. So at this stage with Brugada, the best estimate of risk at 10 years if you have a Brugada resting type 1 pattern is 7% or less of a lethal cardiac event, but we don't know how low that 7% goes. Does it go down to 2%, 1% at 10 years? Drug-induced Brugada patterns have a very low risk, so we can manage those conservatively. It's really this shared decision-making issue in the intermediate risk population, but utilizing genetic and functional testing, I think we can inform risk. We'll be able to inform risk better over the next few years. And those are atypical syncope or symptoms. We will now implant a reveal link to monitor those patients, and a very small proportion we might consider a VT stimulation studies. But I've done 2 VT stimulation studies in the past 3 years in Brugada patients, and we have a very big population. So what's happening in the world of the ECG and the science of the ECG? Well, of course, we now have machine learning and computational techniques to analyze the ECG in more detail than ever possible. And this is being applied a lot, certainly in the EP field, to try and predict if you're likely to have AF from your sinus rhythm ECG, to diagnose hypertrophic cardiomyopathy, to diagnose impaired LV function from a 12-lead ECG without doing an echo. And this all boils down to this concept of how the computer will actually, how an algorithm actually analyzes information. And it starts with clustering data. So for example, if you present an algorithm with some lemons and strawberries, a 3-year-old will be able to tell the difference straight away, but you've got to teach a computer to do it. And what these algorithms do essentially is they cluster features on the ECG and then see if they then correlate with specific phenotypes. So if you start with a picture, for example, of George Washington, you then use a neural network, which essentially means you process a piece of information from the picture initially, maybe dark or light. Then you have another layer of nodes, which then look for edges. Then another layer of nodes that look for something that looks like an eye. Another layer that may look, for example, for curly hair from the 17th century. And then essentially, it's then taught what George Washington looks like. And if it gets it wrong, you then go back and modulate the sensitivity of these nodes and then do it again. So by repetitive testing, you can arrive at very precise differentiation of specific features. And this is precisely what's happening on the ECG. So you can apply this now, for example, for long QT syndrome. If you're sitting in clinic with your patient with a corrected QT interval of 440 milliseconds, but they've got a family history of sudden death, and you're worried, well, maybe they have got long QT or Brugada syndrome. Well, if you run an AI ECG algorithm, this gives you quite an area on the curve about 0.863 for predicting if this patient is a gene carrier for long QT syndrome, even if their corrected QT interval is less than 450 milliseconds, so a pathogenic gene mutation carrier. It can also differentiate between different forms of long QT, from long QT1 to long QT3. You can see it's very accurate for long QT1, 87% accuracy, but you can toss a coin for long QT3. But essentially, it's an indication that utilizing ECG could give you an indication of a genetic diagnosis. So what's the algorithm doing? Well, these algorithms are basically hunting across the QRS and the T wave to look for features on these waveforms that are invisible to the naked eye, and they're looking in 3 dimensions, not on a millisecond by millisecond basis. So you've got a 4-dimensional analysis occurring at about 3,000 cycles per second, analyzing the ECG, so even quicker than Perry can think. And they looked at a population of patients, for example, who were given sotalol, and you could actually predict who was going to have a torsade based on their AI ECG analysis. And so there are 3 applications now, certainly in the channelopathy world or the inherited arrhythmia world, to detect if, for example, a patient is likely to have a ventricular arrhythmia with an IKR blocker. Could be whether you can make a genetic diagnosis on the basis of the ECG before the genetic testing is available, as it were, and also to detect your likelihood of risk potentially of ventricular arrhythmias. Turning to long QT syndrome, there's been a further advance this year using from the Mayo Clinic, where they looked at their long QT registry and looked specifically at females with long QT2 and long QT1, and on the basis of utilizing a combination of the genetic mutation and the corrected QT interval. The innovation here is to actually give you a percentage risk over 10 years of having a cardiac event. We've all been used to dealing with hazard ratios, but again, what you really want to say is you've got a 2 in 100 chance of this happening over 10 years or a 5 in 100 chance of this happening over 10 years. We should think about an ICD according to your threshold of risk. But again, this concept of being able to at least have a number we can use to give us a guide for therapy. And this uses a combination of the QT interval and the position of the mutation. And a couple of other interesting papers, which I think are quite useful for some of us who get called to go to ITU and see a patient who's having recurrent VF. This is a study that was published by Sami Viskin, where he keeps all his ECGs in a cupboard over about 40, 50 years, probably from Bel Hassan before him. And what they did is they studied a group of patients who had VF, either ischemic VF, so they were having an MI and had VF, or they'd been revascularized and were having recurrent VF, but getting a torsade de Pointes pattern or a pseudo torsade de Pointes pattern, as it were, and then long QT patients who had torsade. And what they found was that if you have idiopathic VF, you tend to have if you have ischemic VF, you have a relatively short corrected QT interval. But those patients who weren't ischemic had a corrected QT of between about 350 and 400 milliseconds. So they were in this range. And the important thing here is they get short-coupled PVCs, but they're responsive to quinidine. So this concept of not giving quinidine in ischemic heart disease, if they've been revascularized, and they're getting recurrent VF, and the corrected QT is in this range, and it looks like torsade, quinidine is extremely effective at suppressing recurrent VF. This is a series of patients with short-coupled idiopathic VF or short-coupled VF from the CASPER registry, which is the registry of cardiac arrest patients that have been very thoroughly screened clinically for Brugada syndrome, long QT, and cardiomyopathies, as well as CPVT. And they found that these patients, if you look at the coupling interval of the ectopic beat, if it's less than 350 milliseconds, these patients, again, had the short-coupled VF that was very responsive to quinidine. So again, in this case, simply using the ECG to predict patients likely to benefit from a therapy, a very old drug used to treat fever by Amazonian Indians, and we still use it today. So this is just a summary of essentially the different groups of ectopics, coupling intervals, as it were, that can initiate VF. And the important thing here is just that the response to therapy that one can use. So if you have a very short couple of VF, quinidine, again, pseudo-torsar post-MI, quinidine 320 to 420 milliseconds, and then we move across to Brugada and long QT, where you're more likely to use pacing and beta blockers to suppress ventricular arrhythmia at these longer coupling intervals, but that's the range. So in conclusion, we're certainly making some more progress in Brugada risk stratification. I think the issue, I think it'll improve with using genetic testing and looking at the functional effect of variants in certainly in SCM58 as a starter. Long QT risk is being further risk stratified. I think utilizing machine learning techniques for ECG analysis and probably imaging analysis going forward almost certainly will also be integrated with genomic approaches to enable us to predict risk and response to therapy. And now this issue of using quinidine more post-MI without ischemia and short-coupled idiopathic VF. Thank you.
Thank you very much. That was another wonderful overview. You fitted so much into 15 minutes. I think the phenotyping using AI in those long QT patients as geneticist is really interesting because we know how important phenotyping is. And those nuggets about risk in Brugada syndrome, so helpful. I'd like to introduce Professor Nigel Wheeldon, founding father of the AICC, who's going to talk to us about updates in inherited aortopathies.
Thanks very much. If my slides could go on. I think you might have put the other slides on. I'm using the laptop now, if I may. Can you turn them off? Thanks. Okay, so I'll just get rid of this. We're expecting this to come on with your connector. Put the cable back in again. It's because it's been attached to a Mac, that's the problem. It's coming up on here now. There we are. Okay. So this is why we talk about aortopathy. This is aortic dissection, a catastrophe. Half the patients don't make it to hospital. Of the ones that do, within 48 hours, another half will die. So it has about a 1% mortality per hour without surgical fixation. And you'll see here the dissection in the root going around the arch and right down the back of the chest into the abdomen, lopping off various arteries down the way. So this is a terrible disorder. And just while we're on this picture, just a few thoughts about why it commonly occurs in the root, just above the sinotubular junction, or it commonly occurs just between the arch and the descending aorta for type B dissections. So just hold those thoughts. This is often, but not always, what's behind it: aortic aneurysm, big aneurysm on the CT here, and these are what they look like at theatre. Why are these aneurysms focal here compared to this normal artery? If this is a genetic disease, it affects the whole aorta, supposedly. Why do we get focal disease? Is it hemodynamics? Is it something else? Going back to basics, they occur in clusters in families. So if you have an aortic dissection, you have a substantially increased risk of having a family member with the same, and roughly overall 6-7 times relative risk. If you take out known genetic disease, then that risk falls to about 5, but still you have a 5 times increased risk. And if you flip this around and you've had an aortic dissection, your family members are much more likely, for example, to have Marfan syndrome, 30 times relative risk, although the absolute numbers are still relatively small, given that Marfan's is about a 1 in 5,000 background prevalence. And there's also an increased chance, about 6 times, that you'll find bicuspid aortic valve in the family. Family disease is important. We've heard this before, because if you have a family history of aortic dissection, and you have a dissection, it will occur at a younger age than if you don't have a family history. This is a common theme in cardiovascular genetics, but note that in these patients, non-syndromal patients, the age of dissection is in the 50s compared to much younger in overtly syndromal patients. So why are we so obsessed with syndromes? Non-syndromal disease is really important. It's more common than syndromal disease. It's often familial, typically autosomal dominant. You dissect at a younger age if it's in your family. And this is what I find interesting, that familial cases, non-syndromal familial cases, the aneurysms grow at a greater rate than sporadic cases, and actually at a greater rate than Marfan's cases, which I think is quite interesting, because we all think that the risk is in the overtly syndromal patients. The hypertension story to me doesn't add up. It links to descending but not to ascending aneurysm. I think it's a red herring. And now that we know about mutations, we know that about a quarter of these families, non-syndromal families, have genetic mutations. So this is the sort of picture that we build up of dissection, starting with aneurysm, and going back from the dissection, we find patients are either syndromal or they're not syndromal, and the usual suspects turn up here, and there are others. And in non-syndromal disease, the familial and sporadic forms of dissection, and of course the bicuspid aortic valve is in there. But the problems are that some patients dissect without aneurysm, particularly vascular EDS. And the other problem is that bicuspid valve finds its way into the syndromal patients as well. So it's all very well, we've had a dissection and we work backwards, but of course we want to prevent dissection in the first place. And in this group, the syndromal group, there's something to see that tells us that the patient needs to be followed up because they have a risk of aortic aneurysm and dissection. But of course, if you're non-syndromal, in the absence of screening for thoracic aneurysm, which doesn't exist at the moment, the only way we can get to those patients is through family evaluation after an index case is presented. So it's vital that that happens, otherwise they will just turn up out of the blue as a dissection. So on the basis that a lot of this is genetic disease, we're looking for protein-based structures in the aorta which are susceptible. And these are the groups to think about. The vascular smooth muscle cells are really important. And I'll come back to that in a moment. All the structural proteins that we think about, elastic fibers with fibrillin associated, collagens, particularly collagen 3, and then the matrix proteins. And then, of course, we have the signaling pathways, these apparently mysterious pathways that are present in the aorta. And in this particular environment, we talk a lot about TGF-beta and SMAD, Notch, and the MAP kinase, big family of signaling mediators. But I'll put it to you that the vascular smooth muscle cells are key to maintaining the integrity of the aorta. The aorta is not just some rubber tube that just sits there passively. It's a very active structure. The matrix and the structural proteins are being turned over all the time. Signaling is going on. It's responding to the environment, blood pressure in particular. So it's a very changing structure. And if we interfere with it with a genetic mutation, things start to go wrong. Take a bit of aorta. The bit that matters to us today is the media, which is essentially made up of smooth muscle cells, elastic layers, and matrix. So unlike Perry and Pier, I just break you into these things slowly. It's quite early in the day, so, you know, there we go. Okay. Oh, no, this is nothing, this is nothing. So, very simply, and it is actually quite simple, the bottom third is the nucleus, the middle third is the cytoplasm, and the top third is the extracellular matrix. So this is a junction between the cell and its environment. Okay. So some of the things that we're very familiar with, the structural proteins, fibrillin in particular, linking with elastin, collagen down here, and then the signaling pathways. Notch, very important in development. I'm going to park that for now. The TGF-beta, which is very important to this group, TGF-beta, the receptors, the SMAD, which links it to the nucleus. MAP kinase and fellow kinases. And this I find fascinating, the integrin group. So the integrins are linking the cell with its outside world, and then they are transmitted through the cytoskeletal proteins to the nucleus. And they're responding to things that are happening outside. So as changes occur in vessel wall stretch, these things respond and trigger a response in the nucleus to generate matrix proteins, enzymes, whatever. So it's almost as though the guys on the outside have got all these sort of telephone lines into the protein factory, and they say, chaps, it's not so good out here. Can you give us more of whatever? Or take away some of this. So this is a very active, responsive situation. And you can understand how genetic mutations, which are in the genes in red here, can interfere with this. And if you take any one of these things, and let's take fibrillin, fibrillin's not just a structural protein. It actually has to sort of work with elastin to form the elastic nature of the aorta. And Marfan's patients have a very stiff aorta relative to normal. But fibrillin interacts with the signaling pathways, and this is perhaps more important. It really affects the way that TGF-beta and other pathways behave. And we know, of course, it's linked to root aneurysm. And clinically, we see images like this, and we try and work backwards to infer that the patient might have a fibrillin mutation. And these are the sort of pictures you will see in a Marfan talk, and I'm not going to go through all of these things. But I would say that any one of these things, and actually probably all of them, don't add up to Marfan's syndrome. And if you see a pectus in isolation in a lanky individual, you start having thoughts, if you're that way inclined, but it's nowhere near Marfan's syndrome. It could be one of many things. It could be normality. So we need to be very careful because there are only a certain number of ways that the body can manifest these conditions. The revised Ghent helped. It focused on the things that really matter. Is there a genuine family history of Marfan's, not just tall people? Is there aortic root dilatation? Is there ectopia lentis? Do we have a pathogenic mutation in fibrillin? And it's tightened up the systemic score as well. So we get a better genetic pickup rate, if you like, if we apply these correctly. But just on the systemic score alone, you could have a pectus, a scoliosis, facial features, striae, mitral valve prolapse, and you still don't get enough points to get the systemic score, never mind the rest of the Marfan's criteria. And you will look pretty syndromal if you have all of those things. So you need the others to go with it. And of course, if you have all of those things, you might have Loeys-Dietz syndrome, you might have a TGF-beta mutation, not a fibrillin 1 mutation. And it's all very well that we see the sort of obvious cases. We see the bifid or broad uvula with other midline developmental abnormalities, sometimes cleft palate, sometimes hypertelorism for the same sort of midline developmental reasons, down-sloping palpable fissures, milia on the face, and the arterial tortuosity. When these things are discovered, if you like, these syndromes, it's always the worst cases that we see. And of course, the more you get into these patients and their families, you see incomplete expression of disease, which is really where we learn everything from, not from overt cases like this. And if you take the lowest Dietz patients and you look at down here, you'll see, yes, the pectus and the scoliosis that we talked about before, but these fairly high proportion findings, hypertelorism, clefts or uvula, aortic root aneurysm, but also aneurysms of other vessels. So there are some things that start to separate these cases out clinically. So Marfan's, largely a problem of the aortic root. The pulmonary artery often dilates, but usually in a benign way, usually. But we don't tend to see aneurysms elsewhere. So the diagnosis here is important because it means that if you're managing these patients, you have to go outside of the aorta to do your evaluations. And we commonly have to do MR of the whole major arterial system. If you look further down here as well, ectopia lentis is not represented in this group. So that would be something that would lead you more away from this towards the fibrillin mutations. But on the same note, if you have talipes, joint laxity, translucent skin, aneurysms in other areas, you may not have lowest Dietz, you may actually have a collagen 3 mutation, vascular EDS. Quite rare, but we're seeing a lot more of it now. We've got about 200 cases on our books. It's about 1 in 100,000 in the population. And these patients have a number of things, typically translucent skin with visible veins. They have a propensity to arterial dissection, often without aneurysm. Aneurysms can be pretty much anywhere in medium-sized arteries. They have a fairly typical facial appearance once you get tuned into it. It's the mid-face. They have a sort of fine feature mid-face. They have sometimes quite staring eyes. Ptosis is a feature. In the absence of intracranial aneurysm, it's still a feature. And they can have attached earlobes. They have the mother and father of all varicose veins, and we often hear about varicose vein operations that have gone horribly wrong in these people. So these are the sort of images you see, the pinched nose, the staring eyes, the fine features, the attached earlobes. And this is the point where people start having a little feel of their earlobes, and it's quite common in the general population, I might add, so it's not, the predictive value is very small. But it's very common in vascular EDS. And then this feature, which is acrogyria, the sort of premature aging, if you will. So here's acrogyria again in a vascular EDS patient. You can see the visible veins, the big varicose veins, the abnormal scarring. And there are others. There are the Turners, of course, complicated by coarctation and bicuspid valve. They're the Beal syndromes, which generally have a non-progressive but dilated aorta. So the clinical phenotype can put you in the right area, if you will, but often we use genetic testing, of course, to take this further. And the vascular EDS patients typically don't have a problem in the aortic root. They typically have it in the descending aorta or multiple areas elsewhere. And when we do the surveillance MRs, we pick up celiac aneurysms, carotid aneurysms, hepatic, all the rest of them. And we have to somehow manage these in conjunction with other specialists. Sorry, okay, yeah. And they're associated also with these other problems. I'll not go through the genetic testing with you, but this is a typical panel, and you'll see genes affecting the smooth muscle matrix and signaling pathways. Bicuspid valve is an issue. It typically causes this type of ascending aneurysm rather than the pear-shaped ones, which are much more commonly marfanoid. And aortic stenosis is still the problem, even though aortic aneurysm occurs in about a quarter. Sadly, patients who have bicuspid valves have aneurysms, and if you want to use the bicuspid valve as a marker of an aneurysm in the family, it just doesn't work, because some patients have aortic aneurysms and they give rise to children who have bicuspid valves and vice versa. So the idea that we can screen families to see if the valve is bicuspid, and if it's not, we discharge them, just doesn't work, and that's really unfortunate. Yeah. The smooth muscle cells, which I've said are so important, come from different areas. The aorta is not the same throughout. They come from different parts embryologically, and there's overlap in two areas. Here in the root, and you'll notice in the descending aorta, a very sharp distinction. Could this be anything to do with why problems occur at these areas? The smooth muscle cells behave very differently to signaling. It could be. Is there a common pathway to aortic dissection? There are common pathophysiological findings irrespective of the genetic cause. And in the histology, we see this medial degeneration. And I used to chase histology reports, but they all came out with the same result, all saying the same thing. And I think this is telling me nothing, but actually maybe it's telling us everything, that there is a common pathway. I'm not a surgeon. This is pairs you'll have heard about, external root supports. So this is surgical management. Surgery is not the future. This is the future, and I'll just finish with this slide of the mouse model. So knock-in mice with a glycine mutation to mimic vascular EDS, they all die suddenly. They die of hemothorax, almost certainly, and they die quickly. And it's because collagen and elastic fibers are broken down. If you look at the signaling pathways, the mediators are all increased. So the signaling pathway is enhanced. And if you give drugs to block those inhibitors, you can reverse the problem. And this is ruboxystarin, and we're about to start a multi-center clinical trial with a similar agent in patients. So this is good advice. Keep things simple if you can. I think the message for aortic disease is examine the patient. Sadly, you have to examine them. Look at the pedigree carefully, look for clues. Blood pressure control is not the future. We all need the surgeons at the moment, but they're not the future either. The future to me is very targeted pathway interference, if you like, to get to the specific problem which is behind these conditions. Thank you.
Thank you very much indeed. Shall I move on to Dr. Blair, just in the interest of time? I'll introduce you as you're coming to the lectern. So Dr. Blair is a consultant clinical geneticist based in Oxford, and he also has a role as medical director of the Central and South Genomic Laboratory Hub, and as such is heavily involved in the mainstreaming of genetic services, which we all know is a very hot topic. And I'm interested to hear what he feels about his vision of services going forward. So take it away, Ed.
Thank you very much. Eleanor told me that you get to speak twice at the AICC in your career. Once on the way up, once on the way down. It's good to be back. I had this up as just as an introduction slide, and it's been brilliant actually to come last in this mini session, because a lot of what the speakers have been speaking about before highlight exactly the type of things that I was wanting to sort of bring up in this presentation. And this was just going to be an introduction slide, but actually then I started thinking about mainstreaming in cardiovascular genetics in AICC, and it's been a journey. I've used that word. Sorry, I've used the journey word. Sorry, I apologise for that. But it's been really interesting, and it's actually been a two-way street when I reflected on this over the last sort of 25, 30 years. It wasn't so much mainstreaming genetics into cardiology, but it was a two-way street of learning cardiology and genetics a little bit of cardiology. And yeah, it's been something that actually I think this ICC field essentially has led the way in mainstreaming in genetics. It's almost been like the exemplar. And you sort of think back to, you know, when we were all fighting to try and get these for Christmas, and these were the highest tech sort of computers you could get, brilliant films, and that's what mobile phones looked like. Back in 1998, I can speak with some confidence, because we were in this field, we were working together, And I was thinking back to how we were doing genetic testing back then. And, for hypertrophic cardiomyopathy that Perry was talking about, it was based within research laboratories. I remember getting calls from colleagues in Cambridge or Newcastle saying, can we test this family for hypertrophic cardiomyopathy? And it was one exon at a time, run on acrylamide gels, and you might get an answer for them in months and months or years down the line. And genetic testing was sort of developed through regional centres in genetics or research active groups, maybe in cardiology. And it was very much a hit or a miss what genetic testing was on offer. And the idea of it being a postcode lottery, it was actually very much the case. But through the years, over the last 20 years or so, we've got, new guidance has come out. The National Service Framework, which felt at the time to be just this enormous advance in putting ICCs on the map, and work that people in this audience today were involved in through the Public Health Genomics Unit and published guidance, led to us sort of learning more about what it was we wanted to be doing in ICCs. And in terms of genetic testing, new technologies. I remember when we got one of those in the research laboratory in Oxford. This was called a wave machine. It was just like, this is the future. It was just amazing. But again, it was sort of one exon at a time, and then this was an advance. And now we're doing whole genome sequencing routinely in clinic. And to take an example that's not ICC related, I do general genetics clinics, but we'll see kids with syndromic or non-syndromic learning disability. And our sort of pathway previously was, we'll sort of look at the child, we examine them, take a family history, and then you would do a test, and another test, and another test. This might be single gene by single gene by single gene. And we've all heard the idea of the diagnostic odyssey. Well, that whole process, for me anyway, is completely changed now. I'll take the family history, and I'll look at the child, but I'll do an array CGH, and then pretty much go straight to whole genome sequencing as a trio, and not bat an eyelid about doing it. Totally different paradigm of how we're looking at this, and it's completely revolutionized how we're doing things. This sort of joining together of sequencing technologies and IT has completely changed how we're looking at doing genetics and genomics in the clinic. And so this brings us up to sort of like where we are now. And this is, I'm not going to really talk about ICCs in this presentation. I'm going to just hopefully give you a flavour of where we are at with the new NHS Genomic Medicine Service. What are the aims of the Genomic Medicine Service? I'm going to have to put my glasses on. The last time I spoke here, I wasn't wearing glasses, but now I'm going to have to. The idea is to get rid of that postcode lottery, to give us a consistent, equitable genomic service for the whole population, operating to national standards, specifications and protocols, to delivering, and I'll describe this in a bit more detail, a single national genomic test directory, which will actually cover what technologies tests are delivered by, who can get a test, who can order a test, and which patients are eligible. But also critically as well, to give all patients the opportunities to engage in research and drive forward those new discoveries that we were hearing about in hypertrophic cardiomyopathy and arrhythmogenic conditions and indeed in aortopathies. So this has got to be done by building this single national genomic database where patients that are going through the Genomic Medicine Service can be recruited into. And when you think about back to that sort of brief chat about 1998, who wouldn't support these as aims for where we need to be going in the future and where we're at now? And already you could start to see, well, what would be the sort of benefits? So you might ask, well, what are the benefits of this sort of standardization of the service? Well, getting rid of that diagnostic odyssey, for one, where patients are coming back to clinic year upon year upon year, getting no closer to a diagnosis. Matching people to the most effective medications. We heard in hypertrophic cardiomyopathy, this sort of future vision of, absolutely revolutionizing how we would go about classifying and treating these conditions. Nigel sacked all the cardiovascular surgeons in the country, and we're looking at new drugs for treating aortopathies. But to really target these medicines, and again, cardiovascular medicine can count itself a leader in this type of area of matching treatments to genotypes. To really do that, you need to actually be defining the patients at that molecular level. And again, the research comes through as a big bonus in terms of a genomic medicine service. So what is the structure of these? We've heard mentioned briefly genomic medicine service alliances, the GMSAs. The country's been split up into England. Sorry, I know this is I can't really speak for the devolved nations in this, but England's been split up into 7 regions based upon genomic laboratory hubs. Now, you could reasonably argue that we've gone about this backwards by establishing a laboratory service and then asking the clinical services to fit in, and you wouldn't have me arguing against that. But these footprints define the regions of the country that will be delivering the laboratory services. The GMSAs, which I'll tell you a bit more about shortly, are coterminous with the genomic laboratory hubs. And this is the sort of overall structure where you've got clinicians and patients feeding samples through to the genomic laboratory hubs, which then feed the data back to the clinic. But these also then link in with the genomic medicine service alliances, and a lot of the staff that are involved in the genomic laboratory hubs work through the alliances to help then deliver things like workforce education, training and development that we'll come back to in a bit more detail. Again, this sort of research element of this sort of, in conjunction with Genomics England, which are running some of the larger development projects, again, which we'll come to in a few minutes. So the genomic laboratory, the GMSAs, what is a GMSA? So I don't know if you guys are all completely up to speed with what a GMSA actually is, and I thought it'd be worthwhile just taking a second to describe what their role is. Essentially, it's about embedding genetics into our mainstream practice. So it's making the stuff that you guys have been doing for years much more widespread across other specialities. You know, getting the oncologist to investigate patients who have got cancer, the neurologist using genomic medicine, pediatricians getting more familiar, more aware of using genomic medicine. It provides, the GMSAs are really clinically led organisations, so they've all got a chief medical officer at the top of them, and providing that clinical leadership to develop the networks that we're going to need to sort of roll out the genomic medicine service. They're also about developing new models of care. So one of in the central and south, this is the one, the GLH that I'm responsible for from the West Midlands down to the Isle of Wight. The developing new models of care, one of the ones we're doing is primary care testing for FH. So GPs ordering FH tests in primary care. And these new models, they'll be trialed, they'll be rolled out if they're successful. And different GLHs and GMSAs are doing different programs, which are called transformation programs. And I'll show you those. I think Elijah's going to speak about later this afternoon as well, specifically to AICC. But a lot of the education that's going to be required is coming through the GMSAs. This is another busy slide, Nigel, but I just wanted to point out that there are ICC-related transformation projects. So one of the tools the GMSAs are using they're developing local transformation projects. They've got sort of regional ones where maybe a couple of GMSAs are working together, and then there's these national transformation projects. One's in FH, and one Elijah's going to talk about later on, which is the BHF pilot scheme for ICCs, pathologists and coroners. So I'm not going to touch on that anymore, but it's just to say that these things are starting to happen. Eleanor asked me to talk about the future of genomics, and I actually realised a few weeks ago that I am just not a futurologist at all. Someone asked me, what's genetics going to look like in 10 years' time and 30 years' time? And I hadn't a clue. Literally, my brain just seized up, and I couldn't think what it's going to be like. But cleverer people than me in the government have a plan for genomic services in the future, and it's been published in this document. I don't know if you've all read it, I'm assuming, but I'll skip through it quite quickly. It's got the plan, the future view, is really these 3 pillars with 5 cross-cutting themes. And over the next 10 years, their ambition is to sort of create the most advanced genomic healthcare system in the world, underpinned by scientific advances through the research that's going to be ongoing, with better outcomes at lower cost. The buzzwords are diagnosis and personalised medicine. They're more than buzzwords, actually. They're critical to the type of work that Pier was touching on and Pier was talking about in their presentations earlier, and incorporating the sort of latest genomic advances into the genomic medicine service. And essentially, you'll be seeing the NHS moving in this area from, this is a vision, a treatment, to a prevention organisation. So if we just touch on these, the first pillar is diagnosis and personalised medicine. And the genomic medicine service that we were talking about is a key part of getting that out there, of using genomics in investigating and managing our patients. But there's also key work being done in pharmacogenomics, and a huge part of the work that's getting done is actually in cancer genetics. So, you know, patients with some solid tumours at the moment, such as sarcomas or paediatric cancer patients, or some patients with some hematological malignancies can already access whole genome sequencing of their germline and their tumour. That's going to become increasingly common as we go forward. The prevention part of this, you know, expanding screening in early life. So some of you will be aware that there's plans afoot through Genomics England to whole genome sequence all newborns. So every baby born in the country will have their genome sequenced. And there's a number of reasons given for that. One would be to expand the newborn screening programme. Big thumbs up for me if the diseases are treatable. It makes a difference to the children. Other reasons that are given is that, well, patients will then have their genome ready if they ever needed it. You might argue that we all carry our genome around with us anyway. So that is definitely coming. This is a pilot scheme that will be sort of getting fired up in the next 18 months, 2 years. Using genomics to improve population health. We're already starting to see the introduction of polygenic risk scores into screening models. You know, you might an advanced screening model might be, say, for example, screening for breast cancer. And you'd say, well, we can then add in the polygenic risk score, and there's evidence and data to suggest that polygenic risk scores for cancer can give you a risk equivalent to having a BRCA1 pathogenic mutation if you've got the adverse polygenic risk score. Or you might take women who've actually got a pathogenic BRCA1 mutation and use polygenic risk scores to put them into, actually, you are the really high risk group within this, and you're the low risk group within BRCA carriers. And it might be that we're looking at this within hypertrophic cardiomyopathy, where we already can see evidence of polygenic risk scores can sort of substratify patients into different groups within the sort of typical monogenic disease. It's in here that, you know, I think the word expression was used earlier, and there's penetrance. These are, I talked about them last week, as fig leaves to cover our ignorance. You know, variable expression or incomplete penetrance. And a lot of that's going to lie within these, and we'll be using those. And then, of course, in the field of prenatal diagnosis, where the geneticist and the audience, you know, be working quite readily, but we're going to be using massively increased use of non-invasive prenatal. And then I've already spoke about research, and I won't say too much more here, but part of the Genomic Medicine Service is establishing a national genomic research library. So every patient that's going forward for whole genome sequencing at the moment is consented for the test, and they're consented, or they're asked for consent to be part of this research programme. And the pickup rate in terms of, well, the acceptance rate in terms of the research offer is over 90%. Patients are generally engaged in this if you make that offer. And this is going to be getting rolled out. I think NHS England will want to do this for every genomic test. So whether you're doing a panel for aortopathies or a panel for hypertrophic cardiomyopathy, this research offer is something that NHS England are going to want us to provide. The cross-cutting themes, I won't go into in a huge amount of detail, but it's all up there. But one of the things I really think we do need to be aware of is that we need to, at the moment, we use tools like Nomad. You'll see on the genetics reports you get, the mutations variants not present on Nomad. Nomad population looks very much like me, you know, Caucasian, Western European or North American individuals. We need to be using the Genomic Medicine Service to build on that and bring in a much greater diversity into our population databases. Workforce development and engagement, I'm just going to do separately. But one of the key aims of this is to support industrial growth, to make, if you like, UK PLC the go-to place for genomics in the world. Through this research infrastructure, they'll be developing better IT resources, ideally. And we've already, Pier was speaking about AI. The AI in genomics in terms of analysing whole genome sequencing. the mind boggles at the possibilities that we could have. Busy slide again, but this is really, I just wanted to pick out, Kate Tartan-Brown is the new National Medical Director for Training and Education in Genomics in Health Education England. If you say to me, if you go, but nobody's teaching us about genomics, you're not looking in the right places. So here's a little bit of pointer. The organisation that Kate heads up, Health Education England, are developing loads and loads of online resources that you can go and look at. Some of these are in-depth, some of them are quick reviews, some of them are targeted specifically to cardiologists. The Genomic Medicine Service has done a massive amount of outreach training, and if you've not been contacted by your local clinical geneticists who are involved in this, if you've not been contacted by the teams that you're working with to say, we need to talk about the new Genomic Medicine Service, go and get them, because this is something that we've all been doing. And the GMSAs themselves are specifically targeted with going and doing outreach work and training. I've stole this from the Southeast GMSA website, which is really nice. So what is the actual practicalities for the Genomic Medicine Service for you guys at the moment? Vast majority of tests that are currently done are not whole genome sequencing. Everybody gets their knickers in a twist about whole genome sequencing. But most tests, you won't see a difference. The laboratory where your test is done may well have changed. And so those of you that were used to working with the absolutely brilliant team in the Oxford Genetics Laboratory may no longer have access to those guys. I can only apologise for that. It wasn't our doing. Some AICC tests are moving to whole genome sequencing. And so if you want to order a test for pediatric cardiomyopathy, and all the adult clinicians have just went, phew, breathed a sigh of relief, it'll be whole genome sequencing soon. For example, in Central and South, I'm switching off all the sub-panels that would normally go to that from the 1st of January. I won't be in the office, so the flak will be minimised. But they're all getting shut off. And if you have a pediatric cardiomyopathy patient, it's the first time you've learned about this, Catherine. It'll have to be done by whole genome sequencing if you're in, wanting those tests. And the other GLHs and GMSAs will be doing the same thing. The adult clinicians amongst you who breathed a sigh of relief shouldn't have, in a sense, because actually this is a test that you'll be using to do things like Noonan's testing or metabolic testing. And so a lot of these tests that you might normally just fill in a quick blood form, send it off, will be moving over to whole genome sequencing, which will be the record of discussion and the research consent part of this. 1 minute. This is my last slide. So this is going to touch us all in terms of how we're engaging with it. And I put in here, beware what you wish for. It's because there is going to be this record of discussion and consent process. And we've had to employ a whole new tranche of what we've called genomic practitioners to actually take this research and the consent out of the clinic. And all I do is fill in a quick form and they do everything else for me. And other GLHs and GMSAs are doing similar things. And it might be that, every heavily engaged clinical speciality will need these type of people to take on that sort of work for them. I said, beware what you wish for. And this, I'll just finish on this. I had an email on Wednesday from a guy who I had no idea he had any interest in Marfans. And he's been into the gel data, and he's had a little trawl around the fibrillin genes. And he's emailed me and said, do you know anything about this gene? Do you know anything about the phenotype? I'd like some advice. He says, I found 4 patients who've got copy number variants and 1 patient who's got a big inversion just by looking at the gel data. And then I thought, oh, that's really interesting. But then this morning when I was thinking about that point I'd made on this final slide about beware what you wish for, we would never have found those variants if it hadn't been whole genome sequencing that was doing it. And so it might be beware what we wish for in terms of the extra work it's going to mean in clinic for us, or the extra staff we're going to need to employ to deliver this. But I can fully imagine that NHS England, and maybe even us, are going to be pushing for this single analytical pipeline as we go forward. And more of these tests and investigations will become whole genome sequencing based. Go and look at the training and education stuff on Health Education England website if you've not got in touch with that. Speak to your GLH if you want to get more about what the local setup is for your particular area, and speak to your GMSA and get engaged with the training and education stuff that they will be doing. And I'll finish on that. Thank you.
So I think really all these huge changes underlie why it's so important that we work together as an organisation to support those in cardiology and genetics and moving things forward together. So thank you. I'm going to hand over to Eleanor in case there are any questions.
Yeah, are there any questions from the floor? And likewise in the chat online, there's been lots of chat but not questions, so to speak. So
I have a couple if there's aren't any from the floor, but I want to give people a chance to.
So there's actually,
Put their
John
hands up.
Dean has just mentioned that any tests done only by whole genome sequencing in the UK will no longer be available to patients in the devolved nations either. So equity applies only in England. That's his comment. Thank you, John from Scotland. Ed has a response.
I had a question for Nigel. I remember a chap in aortopathy service who died with that. He said in the aortopathies, and he had half his moustache was white. And I thought at the time he could have a neurocrestopathy. Are you seeing any other patients through your service where you might be suspicious that they've got a neurocrestopathy as the predisposition towards their vaccination or ambulance?
Good thought. Not off the top of my head, frankly. And certainly, moustaches don't come into my sort of clinical examination, frankly. That's interesting.
Yeah, I was thinking about melanocytes.
Yeah,
Yeah.
yeah.
And it's half his moustache was white. Sadly, the chap died.
Can I just, we need to have microphones because the virtual attendees can't hear anyone speaking. So we need to make sure the microphones are turned on and you're speaking into it. So yeah, please, can you just repeat briefly your quick question, quick answer for the virtual attendees?
So, the neural crest development can affect the moustache, actually, because of the melanocytes, and you had a patient where a half-white moustache was associated with aortic root aneurysm, so it's not something that needs to come into our clinical examination.
White moustaches, there you go, an interesting one. Any other questions from the floor or online? We've got one more question in the Q&A online, which I'll just have a look at. So Perry, this one comes to you. Chris Krytov is very interested in your slide on aging and dilated cardiomyopathy. So Chris is very interested in your slide on age and DCM. So he says he hasn't typically routinely been offering genetic testing to anyone over the age of 50 in DCM in the absence of a family history. What do you think, and do you think we need to rethink that approach? It might just check it's turned on at the bottom, press the red button. Perry's response initially is 100% absolutely, we need to rethink.
So whatever we do should be based on data, and we have to decide what the purpose of the test is. So I showed you the prevalence data, and cardiomyopathies are a disease not just of the young, but a disease of middle age and elderly. So it comes down to the phenotype. So if you have a dilated cardiomyopathy, which there's no obvious cause, then there is a significant chance that may be familial whether the patient is 50, 60, 70. We've recently looked at this in dilated cardiomyopathy, and of course the yield tails off as you go on, but it's still 10% over the age of 65 to 70 for dilated cardiomyopathy. So if we have a diagnostic test and a phenotype, I don't think age should be cut off. That to me feels like a ration.
Yeah, I guess that's going to be one of the challenges with the new test directory, which says, you can only do genetic test in someone that has a relative with the same disease process. That's going to be a real challenge that we'll need to take forward, I think, with NHS England. There is another question slightly on that from Lisa Barker as well, remotely. As an autopsy pathologist, seeing lots of people who die with a big heart, is there any way that this can be picked out ideally earlier to suggest, and how can you pick out a possibility of inherited DCM from an autopsy, I presume that is, Lisa, to suggest when family should be referred?
Yeah, so Elijah will be talking about this later. We've been struggling with this, and you'll remember all the discussions we had, 10, 15 years ago. That transition from the coronial system to the healthcare system, it seems really small. It's a chasm. Because you're moving from a legal system with no responsibility to make a diagnosis to a healthcare system, and transitioning in that is very complex. So I think there are systems in place. It varies between different jurisdictions, common jurisdictions. But what we want is someone to flag to a healthcare professional, ideally actually the general practitioner, I think, that this could be familial. But the pathology report is critical in that regard. It has to be directive. This could be a familial disease screen of family.
Excellent, thank you. There's one, another question here. Ooh, if I can manipulate it. Would you like to ask one?
Yeah, I
Just
was
one
interested,
final
Perry, I
question.
had a question along a similar line in terms of have we got the balance right in who we suggest screening for in the absence of a informative genetic test, bearing in mind that increase in data, but also bearing in mind we have to think about using our services where they'll produce most patient impact rather than detection. When will it result in change in management?
Practical question. Because I think all inherited cardiac disease services, whether it's in the UK or elsewhere, are suffering the same problem. We have exponential growth in the number of healthy people that we're bringing back every year to screen. So I think that to me is one of the most valuable roles of genetic testing. There's a sort of an initial triage process if you can identify a mutation in the proband and stop screening relatives for whom you don't have and who are non-carriers. But still, I think as Pier knows, I'm an AI cynic, but developing models which take into account the phenotype and the probability of A, genetic disease, and B, whether or not it's going to be penetrant within a 5 or 10 year or 15 year period, we've got to get smarter because we can't keep seeing a load of healthy people.
And I have a question for Nigel, unless anybody else has got any others. Oh, sorry. That's a comment, really, isn't it?
Yeah, no, there's a, yeah, no, don't worry.
Nigel, I just had a quick, well, it's probably not a quick question, actually. You made the point that the blood pressure doesn't add up for the aneurysms and dissections, and a very simplistic model might be a higher pressure system is under more stress. So I don't know if you could give us just a few pointers as to why you're not convinced of that being an important causative factor.
Yeah, I mean, most people with these aneurysms, particularly genetic young patients, have not got hypertension to start with. You might argue they might have a relative hypertension. All the trials that have been done have been confounded. All the data that we have in basic science, like the mouse studies that I showed earlier, all those studies were done with antihypertensives, and you can actually lower blood pressure in mice very effectively. Made absolutely no difference either to signalling or to outcomes at all. We've been through numerous trials over the years with established drugs, beta blockers, sartans, more recently. And the results have been poor. Marginal changes in the aorta, confounded again by blood pressure. It's just not convincing, very unconvincing. And of course, if you want to take it forwards and actually start treating patients, you're going to have to lower normal blood pressures to presumably ridiculously low levels. It just ain't the way forward. It's been our approach because that's all we've had to go on, really. We think, well, blood pressure must be the cause of this, or it must contribute to it. But actually, I'm not convinced personally, and I don't think many people are.
Thank you.
So in the interest of time, I'm going to draw the questions to a close with a final comment, actually, to say, Pierre, I liked your thoughts with regards to AI. Anyone that knows me knows that I try and do my best with tech and integrating it into clinical practice. But actually, our brains are no longer able to integrate the amount of complex data that we're dealing with. So there is a potential future with AI, which we'll hear about later. But actually bringing together genotype, phenotype, and trying to risk predict, but trying to also detect diagnoses for those of us that don't do ICCs, or for our junior colleagues we work with, to highlight if someone has X gene abnormality, or say they have Brugada, and auto flags if they're going to be prescribed a medication on the electronic patient record system. There are lots of potentials here with tech. So thank you very much to our speakers from the first session. Please go and grab a coffee. We will be back for 10:45, so it's not very long, I'm afraid, but thank you very much.